Imagine you're an architect, right? And someone hands you this massive, incredibly detailed blueprint for a 100-story skyscraper.
Okay, sounds like a good start.
Right, but as you unroll it, you realize there are absolutely no labels.
Oh, wow.
Yeah, there's no compass rose pointing north. You look at a drawn line and you have like no idea if it represents a solid load-bearing steel beam, a hollow ventilation shaft, or just, a cosmetic wall.
That would be a nightmare.
Exactly. If you try to renovate that building or, I don't know, fix a structural flaw, you are flying completely blind. You're probably going to knock the whole thing down by accident.
Just because you don't understand the foundational language of the map.
Yes. And today, we are going to look at the most complex, high-stakes skyscraper in existence, which is, of course, the human body.
The ultimate architectural challenge.
It really is. So welcome to this deep dive, where our mission for you, the listener, is to decode this secret invisible grid used to map our own anatomy. We're pulling from foundational medical terminology and anatomy texts to explore what are known as body planes and cavities.
Which I know might sound like dry textbook vocabulary at first glance.
Right, totally.
But the reality is anything but dry. This invisible grid is the ultimate medical blueprint.
Yeah, we're not here to just memorize flashcards today. We want to understand how these specific, highly regulated terms are the literal foundation for every surgery ever performed.
Every single medical image taken.
Exactly, and every way we move our bodies. And, as we'll see from the source material, misunderstanding this grid isn't just an academic mistake. It can literally be a matter of life and death.
Oh, absolutely.
Okay, let's unpack this. Before anyone can slice into a map or a body, there has to be an agreed-upon north, right? You have to set the home orientation on your GPS system before you can even calculate a route.
Right, you need a starting point.
And in the human body, this GPS home setting is called the anatomical position.
Yeah, and the anatomical position is the mandatory reference posture that makes all those directional terms meaningful.
Because humans move, obviously.
Exactly. Without it, words like front, back, upper, and lower are completely ambiguous. The standard anatomical position is defined very specifically. It's a person standing upright, facing forward, feet flat and parallel to each other, arms at the sides.
Okay, sounds normal so far.
But the critical and often missed detail here is that the palms of the hands must be facing forward.
See, palms facing forward feels a bit unnatural, though. I mean, if you're just waiting in line at the grocery store, you let your hands hang naturally.
Right, right.
And your palms usually face inward towards your thighs. So why force the hands forward for this medical map?
Well, it comes down to the bones in your forearm. When you let your hands hang naturally with your palms facing your legs, the two long bones in your forearm, the radius and the ulna, they actually cross over each other.
Oh, like in an X shape.
In an X shape, yes. So if a surgeon or a physical therapist is trying to describe a specific location on the arm, crossed bones create a total spatial nightmare.
That makes sense.
By rotating the palms forward, you uncross those bones. They lie perfectly parallel. This gives clinicians a consistent, non-ambiguous starting point for describing any rotation, injury, or movement of the limbs.
Wow. Okay, so once we have our body locked into this GPS home position, we could start drawing lines through it to organize it.
Right.
And the sources detail three main, mutually perpendicular planes that generate every standard slice of the body. So you have the sagittal plane, the coronal plane, and the transverse plane.
Let's break those down. First, the sagittal plane. This is any vertical flat surface running front to back, dividing the body into right and left parts.
Now, people often assume that sagittal only refers to a cut straight down the exact perfect middle of the face and torso, right?
Yeah, that's a really common misconception.
Because the texts make a really important distinction there. A cut right down the exact midline is specifically called the mid-sagittal or median plane.
Exactly. That splits the body into perfect, equal right and left halves.
But if you shift that front to back cut an inch to the left or an inch to the right, so you end up with unequal portions, it's called a parasagittal plane. It's still a sagittal cut, it's just off-center.
Right. Then running perpendicular to that, we have the coronal or frontal plane. This is a vertical plane running side to side, dividing the body into anterior, meaning front, and posterior, meaning back portions.
Okay, got it.
And finally, there is the transverse plane, which you'll also hear called the axial or horizontal plane. This runs perpendicular to the body's long axis, severing it into superior or upper and inferior lower parts.
This actually brings up a question about that transverse plane. This is what we call the horizontal plane.
Sure.
Does that mean literally horizontal to the floor of the room you're standing in?
I see what you mean.
because I'm picturing a patient lying flat on their back inside a CT scanner. If the machine takes a horizontal slice relative to the hospital room itself, it would essentially fillet the patient from head to toe.
What's fascinating here is how rigid this reference system actually is. All directional terms and all of these planes are permanently locked to that standing anatomical position,
Wait, regardless of how they're lying down.
regardless of how the actual patient is positioned in reality. So if a patient is lying supine, flat on their back on a CT table, a transverse or axial plane still cuts them into upper and lower halves.
Oh, wow.
The mathematical plane follows the body's own internal axis, not the room's gravity. The medical terminology tracks the patient.
That is so wild. The words themselves are so specific, though. Sagittal, coronal, transverse. Where did we even get this vocabulary? Like, who decided a side-to-side cut should be called coronal?
Well, the linguistic history is deeply tied to the Renaissance. Coronal actually comes from corona, meaning crown.
Like a literal king's crown.
Exactly. Early anatomists named the suture that runs ear to ear across the human skull the coronal suture, because it's exactly where a traditional crown would sit on the head. A coronal plane follows that crown line straight down through the body.
That is amazing. And what about sagittal?
Sagittal comes from sagitta, the Latin word for arrow.
An arrow.
Yeah, there is another suture on the skull running front to back, intersecting that crown line. The early anatomists thought this seam looked like the track an arrow would leave if it were shot straight through the front of the head.
You are kidding me.
Not at all. So any plane running parallel to that arrow track is a sagittal plane.
It is absolutely crazy that a modern radiologist sitting in a dark, climate-controlled room looking at a multi-million-dollar high-tech MRI is using terminology based on 16th century people imagining arrows shooting through skulls.
It really is wild when you think about it.
How did we end up standardizing this? I mean, humanity didn't just wake up one day with a perfectly functional anatomical GPS.
No, not at all. It took a literal medical rebellion. Yeah. For over a millennium, medical teaching in Europe was entirely dominated by the 2nd century writings of a Greek physician named Galen of Pergamon. Galen's texts were considered absolute, unquestionable dogma.
But the sources point out a massive flaw in Galen's work. Human dissection was heavily restricted in the Roman world.
Right.
So he wasn't even looking at human bodies.
Exactly. He was relying heavily on animal analogs, primarily Barbary macaques and pigs, and he just assumed human internal anatomy was completely identical.
Which is a huge assumption.
Huge. And because his work was protected by cultural and religious dogma, those errors were passed down as absolute fact for over 1,300 years.
That is mind-blowing.
That finally changed in the 16th century with a Flemish physician named Andreas Vesalius. He began performing his own actual human dissections.
And Vesalius publishes this massive atlas in 1543, right? The Humani Corporis Fabrica, on the fabric of the human body.
Yes. And in that publication, Vesalius meticulously documented hundreds of places where Galen's animal-based descriptions completely failed to match actual human cadavers.
I bet that went over well.
Oh, it caused an uproar. But to prove his findings and correct the historical record, Vesalius needed a consistent reference frame. His readers needed to know unambiguously what a slice through here meant without any room for interpretation.
Right.
The entire convention of a fixed standing reference posture basically grew out of this desperate scientific need to establish objective, shared observation.
It took a remarkably long time for that Renaissance rebellion to become the slick international standard we have today, though.
Oh, centuries.
The text mentions it wasn't until 1895, with something called the Basel Nomina Anatomica, that there was even an attempt at a unified international list. Doctors in different countries were still using wildly different terms for the exact same body parts.
Even modern standardization is a relatively recent phenomenon. The current reigning standard, the Terminologia Anatomica, wasn't published until 1998.
1998, that's practically yesterday.
I know. That is the document that finally, officially listed axial as an accepted, standardized synonym for transverse.
Okay, here's where it gets really interesting. These planes aren't just invisible lines on a Renaissance drawing. They're the actual slices of data we use to hunt for disease in a living person.
Exactly.
I like to visualize it like slicing a loaf of bread.
Oh, I like that analogy.
Right. So if you take a loaf of bread and slice it crosswise, like you're making a normal sandwich, you see a specific pattern of air bubbles and grain in the dough.
Sure.
But if you take that same loaf and slice it entirely lengthwise, end to end, you reveal a completely different network of bubbles. You haven't changed the bread at all. You've just changed the plane of observation.
That is an excellent way to visualize it. In clinical practice, choosing the correct angle to slice the bread is everything. Different diseases hide in different planes.
Like what?
Take stroke imaging, for example. When a patient arrives at the emergency room with sudden weakness or slurred speech, the medical mantra is time is brain. The longer a stroke goes untreated, the more brain tissue dies.
Right. And the sources say the very first imaging study they do is almost always a non-contrast CT scan of the head in the transverse or axial plane,
Yes.
the horizontal cut. Why that specific plane when every second counts?
Well, it comes down to scanner geometry and the physical shape of the human skull. A transverse plane allows the machine to capture the entire volume of the brain in the fewest possible slices.
Ah, so it's about speed.
It is the most mathematically efficient way to quickly spot a brain bleed or ischemia, which is severely restricted blood flow, so doctors can make immediate treatment decisions.
Wow. And that same transverse plane is heavily used in obstetrics, too, for fetal ultrasounds.
Yes, obstetrics relies on the transverse plane to measure the biparietal diameter.
Well, what now?
The biparietal diameter, that's the distance straight across the fetal skull, and it's a primary metric used to date the gestational age of the pregnancy and ensure the skull will safely fit through the birth canal.
Oh, I see.
But to get an accurate measurement, the sonographer must acquire a perfect transverse plane. If they tilt the ultrasound wand even slightly, so the plane is off-axis, they end up measuring an angled oval instead of the true cross-section.
Oh, that makes sense. It distorts the shape.
Right. That ruins the math and can throw off gestational age dating by clinically dangerous margins.
Okay, so the horizontal cut is crucial for the brain and the skull. But what if a doctor is looking for an issue that isn't spread out horizontally, but is instead shifting downward? The sources bring up a condition called a Chiari malformation.
Yes, that is a perfect example of when the sagittal plane is mandatory.
Okay.
A Chiari malformation is a condition where the cerebellar tonsils, which, by the way, are structures at the very bottom of the brain, not the tonsils in your throat.
Good clarification.
Yeah, these brain tonsils descend downward through the base of the skull and crowd into the spinal canal.
And you can't see that downward drop clearly on a horizontal slice.
Not with the precision you need. The standard diagnostic view for this is a mid-sagittal MRI. It cuts the brain and upper spine perfectly into left and right halves.
Because that shows the whole vertical stack.
Exactly. It is the only slice that clearly displays the cerebellum, the brainstem, and the spinal cord, all stacked in one continuous vertical line. Radiologists look at that exact mid-sagittal view to measure if the brain tissue has descended 5 millimeters or more past the skull base.
And that's the trigger for surgery.
That is the threshold that prompts further surgical treatment, yes.
We've covered the horizontal axial slice and the front-to-back sagittal slice. What about the coronal plane, the side-to-side cut? Where does that become the gold standard?
Otolaryngologists, ear, nose, and throat surgeons, they rely heavily on the coronal plane when planning functional endoscopic sinus surgery, known as FESS.
Because sinuses drain downward through the face.
Precisely the reason. A coronal CT scan cuts right through the face, perfectly perpendicular to the natural vertical drainage pathways of the sinuses.
Which gives them the best view of blockages.
Yeah, it reveals subtle blockages, polyps, or anatomical quirks in those tight drainage spaces that a horizontal axial view would completely miss or visually distort.
So the planes are the mathematical cuts. They're the angles we choose for our loaf of bread. But what are those planes actually cutting into?
The cavities.
Yes,
Yeah.
This brings us to the body cavities. And I really want to push back on this word cavity because honestly, it makes you think of a dark, empty cave.
Right.
Or like a hole rotting out the side of a tooth. The word implies a void.
The terminology is definitely a historical artifact because the body cavities are the exact opposite of an empty void. The primary map divides the body into two major cavities. The dorsal cavity, located toward the back, tightly holds the brain and spinal cord.
Okay.
Then you have the much larger ventral cavity in the front of the body.
And that big ventral cavity is subdivided by the diaphragm muscle.
Yeah.
Giving us the thoracic cavity in the chest for the heart and lungs, and the abdominopelvic cavity below it for the digestive organs.
You've got it.
But going back to the terminology, these spaces are not empty caves waiting to be filled. They are densely packed with organs, which we call viscera.
A much more accurate visualization is to think of the inside of a car engine.
Oh, I like that.
An engine block is a tightly enclosed space packed with belts, pistons, and moving parts that are constantly grinding past each other. Just like a car engine requires motor oil so the metal parts don't generate friction and destroy themselves, our densely packed internal organs require constant lubrication.
And the sources refer to this lubrication system as serous membranes.
The cavities are lined by these specialized membranes, yes. You have the pleura surrounding the lungs, the pericardium wrapping the heart, and the peritoneum enclosing the abdominal organs.
And what do?
These membranes constantly secrete a thin, slippery, serous fluid.
If we connect this to the bigger picture, consider the actual physical mechanics of being alive. Your heart beats around 100,000 times a day, physically expanding and contracting. Your lungs inflate and deflate over 20,000 times a day. Your intestines are constantly undergoing peristalsis, which is that rhythmic muscular squeezing that churns and moves food through your digestive tract.
If all of those moving, expanding organs were just sitting dry against each other inside an empty box, every single heartbeat and every single breath would literally cause friction burns against the cavity walls. The tissues would shred themselves. That serous fluid is the biological motor oil preventing internal damage.
The texts even point out that if one of these cavities actually does become an empty space filled with air, it's a massive medical emergency.
Why, certainly.
Like a pneumothorax, where air physically breaches the pleural cavity and the pressure collapses the lung.
Yeah, you do not want an actual empty void in there.
Whoa, and I have to ask about this embryology detail from the sources. We talk about the chest cavity and the abdominal cavity as these distinct separate boxes, but that's not how we start out, is it?
It's a surprising fact for many outside of biology. Humans don't develop as a stack of separate boxes. We start out as embryos with just one single continuous internal cavity called the colon.
Just one.
Just one. It's only later in our fetal development that the diaphragm muscle grows across the middle of this space, partitioning the single colonum into the separate thoracic and abdominal cavities we recognize in adults.
It's a brilliant piece of developmental engineering.
Yeah.
But any system of engineering, no matter how highly regulated, is going to have blind spots.
True.
And the sources highlight some massive, life-threatening quirks intentionally built right into the middle of this grid. The single most consequential controversy here isn't just an academic debate over Latin words. It is a massive, persisting patient safety issue.
You're referring to the left-right flip hazard in modern radiology.
Yes. It is wild that this is still happening.
It's a deeply entrenched danger. The standard radiological convention across the medical field is to display axial or transverse CT and MRI images as if the viewer is standing at the foot of the patient's bed, looking up toward their head.
Meaning the patient's actual right side appears on the left side of the computer monitor.
Yes.
That is so confusing.
This convention started decades ago in the era of physical X-ray film, where a doctor would literally stand at the foot of the bed and hold the film up to the light. The patient's right leg was on the doctor's left side.
Okay, I can picture that.
Today, everything is digital, but that backward convention persists on modern screens. It is a primary driver of wrong-side surgeries.
Which is terrifying.
A surgeon under immense pressure glances at a scan. Their brain instinctively processes the left side of the monitor as the left side of the body, and they end up operating on the healthy kidney or removing the wrong lung.
It's like designing a car where the steering wheel is permanently installed backwards, so you have to turn left to go right. But keeping it that way forever just because that's what the older drivers are used to, why hasn't this been fixed?
This raises an important question about systemic risk management in medicine. Do you fix a flawed legacy system, or do you manage the hazard?
I mean, I'd say fix it.
You'd think so, but regulatory bodies like the Joint Commission in the U.S. have determined that flipping the screen convention now would be too dangerous.
Really?
It would relocate the risk onto millions of practicing doctors who are already deeply accustomed to the backward flaw. The sudden change would likely cause a massive spike in catastrophic errors.
So they treat the medical imaging convention as a known, permanent hazard that just has to be engineered around.
They mandate a formal preoperative timeout, part of what's called the Universal Protocol.
Okay.
The surgical team must step away from the backward images, and physically double and triple check the surgical site on the patient's actual body before making an incision.
That is a terrifying compromise, and that's not the only clash in the system. Earlier, we mentioned that the official Terminologia Anatomica treats the words axial and transverse as synonyms.
For the whole body, they are interchangeable. But that conflation creates real confusion in pathology reports when you are dealing with a localized structure that has its own long axis, completely distinct from the body's main axis.
Like an arm.
Yeah, think of an arm pointing out to the side, or a winding blood vessel. A transverse slice through a blood vessel means a cut perpendicular to the vessel's own flow.
Okay.
But that local cut might not align at all with a body-wide horizontal axial plane. Treating the two words as identical has caused serious miscommunication between surgeons and pathologists about how a biopsy specimen was actually oriented when it was removed.
And then, just to humble our human-centric map completely, veterinary anatomy uses entirely different rules. Because a quadrupedal animal, like a dog or a horse, doesn't stand bipedally.
Right, a dog walks on four legs with a horizontal spine. If you try to apply a human anatomical position to a dog, words like anterior for front and superior for above become completely ambiguous.
Because their front is facing down, technically.
Exactly. Is the dog's back its posterior or its superior?
The system breaks down.
Completely. So veterinary anatomists use a parallel distinct system called the nomina anatomica veterinaria.
Sounds fancy.
They rely on terms locked to the animal's biology, regardless of posture. Cranial, meaning toward the head, caudal, toward the tail, and dorsal and ventral for the back and belly. It's a great reminder that our rigid anatomical position isn't a universal law of biology. It is a highly specific, arbitrary human convention.
So what does this all mean for you, listening right now? Why should you care about anatomical position in sagittal planes if you aren't in medical school?
It's a fair question.
Well, anytime you read your own medical chart or try to decipher an MRI report, this is the shared vocabulary connecting your doctors. But it applies to your daily life, too. If you go to a physical therapist for an injury, they will likely assign you a multiplanar rehabilitation program.
Yeah, that's really common.
Because gym workouts heavily default to the sagittal plane, like bicep curls, squats, running on a treadmill. Everything is moving straight forward and back. But real-world injuries, like rolling your ankle on a curb or pulling a back muscle while twisting to grab a heavy grocery bag, usually happen in the frontal or transverse planes. If your fitness routine doesn't train those specific planes, you leave your architecture highly vulnerable to collapse.
And there is one final, incredibly high-stakes application of these planes that we haven't touched on yet, coming from the realm of forensic pathology.
Oh, forensics.
Medical examiners use these exact same anatomical planes to map out wound trajectories in autopsy reports. Think about a high-profile criminal case involving a shooting. The forensic pathologist has to describe the exact path a bullet took through the body.
The precision of the terminology could change the entire narrative of a crime scene.
Entirely. If a lawyer or a jury misinterprets a parasagittal trajectory, which implies a front-to-back angle for a transverse one, which is strictly horizontal, it misconstructs the physical reality of the event.
It changes everything.
It changes whether a victim was standing upright, turning away, or falling to the ground when struck. In a courtroom, the precision of this invisible anatomical grid can literally be the difference between a conviction and an acquittal.
From 16th century anatomists imagining arrows piercing skulls to a medical examiner in a courtroom today proving the exact trajectory of a bullet, the map hasn't changed, just the stakes.
It's pretty incredible.
It really is. Thank you for joining us on this deep dive. The next time you look at an X-ray or even just stretch your arms out at the gym, take a moment to appreciate this secret, invisible skyscraper blueprint holding it all together. Keep questioning the grids that map our world.